So welcome everybody to the Psychotherapy and Counselling Union's NHS emergency meeting. Like I said, I'm Juliet Lyons. I'm General Secretary of the Psychotherapy and Counselling Union, and I'll be chairing this meeting. So I'd like to do some introductions. I know people have already introduced themselves, but I'll say again, I want to introduce the PCU NHS campaign group who organised this meeting. So that's Andy Price, Gavin Robinson and Paul Atkinson. Paul also started the campaign for universal access to counselling and psychotherapy, which is supported by the PCU NHS campaign group. Our administrator Milton Sattler is also supporting us in organising this event. And thank you all for being here today. Supporting the return of our NHS to the public is so important, and how we care for each other through illness is so important. What we're losing in the current legislation is devastating. The National Health Service is being broken down and sold off, but I'll leave our speakers to explain the details and implications of this. We have here today Greg Dropkin and Alia Butt, who have enormous expertise in this field. Greg will be talking generally about the NHS and the healthcare bill, and Alia more specifically about the implications for psychotherapists and the mental health bill. They'll talk for 15 minutes each, and then we'll take questions for 30 minutes, and we'll have another 30 minutes of more free-flowing conversation. And I'll close the meeting at around 9:15. So Andy, if you could just take us through the Zoom instructions for this meeting, and then I will introduce Greg.
Okay, thanks, Juliet. Just a few things. We've got the chat set up so that if you want to ask a question, you can put a question in the chat, but you won't be able to interact with each other. It's just to allow less traffic and allow us to keep an eye on the questions. And Gavin will be collating them and then asking them later on. Or if you want to make a contribution, you can do, and you'll be unmuted and be able to say what you want to do. If you want to do that, then just raise a hand under the reactions, or if you've got the blue hand, either way we'll pick it up. I just did it with my thumbs up just earlier on when Julia introduced me. We are recorded, so just be mindful of that. And if anyone is not happy with being recorded, then keep your video off, and you can still ask questions, but you just do it through the chat function. I don't think there's anything else I need to talk about, because I think we're all pretty Zoom competent now after 18 months of it all. So I'll leave it there, Juliet. Okay.
Great, thank you, Andy. So Greg, I'll introduce you. Greg has been active in Keep Our NHS Public Merseyside group, and is a member of the National Keep Our NHS Public Working Group on Integrated Care Systems. He's active in campaigning against Private Finance Initiative, PFI, privatisations of GP surgeries, and the NHS and charges imposed on migrants. Welcome, Greg, and go ahead.
Okay, I'm here. I'd just like to say in passing that I think the experience we've had in the last 5 minutes should give people some pause if they're wildly enthusiastic about the idea that you can substitute human interaction with computer technology. I think we've seen exactly how that might work in the last 5 minutes. And I don't mean that as a criticism. I think it's a great illustration of what the government is trying to do now. But anyway, okay, so in this first part, I'm actually going to read what I have to say, and it is entirely about the bill. It's not about any other aspect of the NHS, and then we'll hear from Alia. Okay, so Alia and I are going to talk about the health and care bill in relation to privatization and the impact on the workforce and on your profession in particular, but I'm going to start with some of the background. The short version of this, if you like sound bites, is this: the NHS is now in mortal danger after 40 years of attack. The latest Tory plan is opposed by Labour, but given their history, it actually all depends on what unions and communities do. So the idea of a universal comprehensive national health service, publicly provided, publicly financed through general taxation, publicly accountable, free at the point of use with decisions taken on clinical grounds without reference to ability to pay, has been under sustained attack for decades. Back in 1982, Thatcher's cabinet considered replacing the NHS with private health insurance, but rejected this as political suicide. Nevertheless, she managed to introduce competitive tendering so that hospitals would compete with the private sector for cleaning, catering, portering, and laundry services, to import hospital general managers from the private sector, and eventually separate the commissioning of health services from their provision. This was the so-called purchaser-provider split, which is a market mechanism. During the 1990s, Major introduced PFI to build new hospitals at highly inflated costs using private finance. And this scam was promoted by the Blair government, which also introduced competitive tendering for community services, private diagnostics, patient choice, including a private option, privately run independent sector treatment centers for elective operations, and variations to the GP contract allowing private firms to run surgeries. During the global financial crisis, Gordon Brown asked McKinsey Corporation to advise on how to reduce the NHS budget. And McKinsey recommended three things: annual efficiency savings to cut the cost of providing health care, reducing the treatments available on the NHS, and moving care out of hospital to cheaper alternatives in the community. McKinsey are a US-based global consultancy, and they helped draft the 2012 Health and Social Care Act passed by the Tory Lib Dem coalition. In 2012, Simon Stevens, a former Labour councillor and advisor to Blair, who had become an executive director for the largest US healthcare corporation, United Health, led a World Economic Forum workshop on the future of healthcare. And then in 2014, he was appointed as chief executive of the NHS England and issued the 5-year forward view, which was based on the World Economic Forum recommendations. Parliament never authorized this, but NHS England implemented the plan anyway to create sustainability and transformation partnerships, STPs, and accountable care systems directly modeled on the US care model. And they were then simply renamed as integrated care systems. And that's what we're talking about now. And what the Health and Care Bill is going to do is it's going to give these integrated care systems formal legal status. So the rest of this is entirely about the bill. In February, the government issued a white paper based on NHS England recommendations, and the bill was eventually published shortly after Matt Hancock resigned. And at the second reading, Labour tried to get it withdrawn and then voted against it. And the committee stage has now started on the 7th of September, and the third reading is expected in November. The timing is significant if you think about COVID. The bill is being spun as integrating care, which is an apple pie phrase, an undefined apple pie phrase. It's also being spun as ending privatization and learning the lessons of the government's supposedly successful response to COVID. Well, if that's success, I don't know what failure is. But anyway, the lesson they learned was full cooperation with the private sector. And this includes an expensive private test and trace system that did not work even after a year when cases and contacts of the emerging Delta variant could have been identified and isolated if the relevant local public health teams were told in time, which didn't happen. The spin about ending privatization comes from the repeal of Section 75 of the 2012 Act, which required tendering of clinical contracts. But in fact, the bill will actually expand private sector involvement, and that's what I'm going to explain shortly. The next thing to understand is fragmentation. The national NHS will be broken into about 40 or 42 separate systems. Each area will have two new bodies: an integrated care board, the ICB, and an integrated care partnership, the ICP. The ICB will manage the entire NHS budget for the area. Private sector reps may be appointed to the board or its committees, which will have delegated powers. Virgin is already on the board of the informal integrated care system in Bath and Northeast Somerset. Local authorities are guaranteed one seat between them. So in Cheshire and Merseyside, 12 or 9 now, local authorities are guaranteed to have one seat. The public is certainly not going to be on the board, and they may or may not even get to ask questions. NHS England will allocate the budget and they will appoint a chair, but subject to approval by the Secretary of State. The chair will then appoint a chief executive, subject to the approval of NHS England. The ICB will make a binding plan for the NHS providers in the area. They will share the financial risk to meet budget constraints, and NHS England may intervene to limit spending, in other words, cuts. Meanwhile, the partnership, the ICP, will draw up a strategy to which the ICB must have regard. The ICP will incorporate all the local authorities and can appoint unspecified others, we don't know who. NHS England guidance mentions voluntary community and social enterprise, social care providers who are mainly private, and organizations with a relevant wider interest. Now that could be anyone. The next thing is that, very surprisingly, the bill removes the requirement to provide NHS hospital care in each area, although primary care must be provided. The Secretary of State will have the option of designating those persons for whom the ICB has core responsibility as being those who normally live in the area, but he doesn't have to do that. It may not happen. And even more amazing, there's no longer any requirement to provide emergency services for everyone present in the area, which is a current responsibility of CCGs. And it's really hard to imagine how that would work. You know, somebody has an accident, but they don't live in the area, so who's paying for it, and so on. So aside from the board and the committees, there are other ways in which the NHS is going to be opened up to the private sector, and I'll outline 4 of them. The first one is the payment scheme. In deciding the budget for each system, NHS England will consider the cost of treatment and services that they expect it to deliver. Currently, those costs are set by a national tariff, but that's not how it's going to work. They will be set by a new payment scheme with prices which vary according to where, by whom, and to whom the treatment or service is given. NHS England must consult on the scheme with anyone who provides healthcare services for the purposes of the NHS or for the purposes of the Secretary of State's public health functions. For example, sexual assault referral centers are a public health function. Some SARCs are run by G4S, so G4S must be consulted on the payment scheme. I'm sure you know about them. The second issue is procurement. The bill will allow contracts to be awarded without open tenders. Since May 2020, over 4,700 COVID contracts worth £38 billion were handed out, many of them without procurement, some to politically connected firms with no relevant experience. And as the explanatory notes to the bill reveal, any tenders involving clinical services, including mixed bids with a clinical component, will be exempt from the Public Contracts Regulations 2015, which derive from European law. But that doesn't end privatization, which is how it's being spun. It replaces a regulated market by an unregulated one, without the safeguards for compliance with environmental, social, and labor legislation, including ILO conventions such as freedom of association and the right to strike, or the right to examine whether the bidder could actually deliver, which didn't happen with some of the PPE contracts. The bill simply scraps these safeguards. The third privatization aspect is something called the Health System Support Framework, which is quite a key thing, but not very well known. The current situation is that over 200 organizations, almost all of them private companies, are accredited by NHS England to support the development of integrated care systems. And they include McKinsey, who we've mentioned, Optum, which is an arm of United Health that Simon Stevens used to work for, IBM, Cerner. There's a slew of US firms involved in this, 30 at least. And these are firms which either provide health insurance or supply consultancy and data services to the US insurance industry. Now, one of them is Operos, which is the UK arm of the US health insurance and data analytics giant Centene. Operos now controls dozens of GP services in England, and its former chief executive, Samantha Jones, now advises Johnson. The Health System Support Framework accredits Operos for 22 topics, including population health intelligence, development of service change, and reconfiguration proposals, personal health budgets, and so on and so forth. And I'll just talk about one of the many topics in this slew. It's called actuarial assessment. And what this means, as you may know, is to bypass clinical evaluation in favor of a statistical analysis to predict risks. Well, does it work? Well, not according to the Royal College of Psychiatrists, who reviewed the whole thing. They reviewed the use of this technique to estimate the risks to others in mental health services, and they concluded that a structured professional judgment approach to assessing risk is preferred to actuarial or unstructured assessments. And then another paper in the British Journal of Psychiatry evaluated two popular actuarial risk assessment instruments and concluded the ARAIs cannot be used to estimate an individual's risk for future violence with any reasonable degree of certainty and should be used with great caution or not at all. The fourth issue here is data sharing. The bill intends a massive shift towards digital services and sharing information. And the explanatory notes explain that NHS Digital may only share information for purposes connected with the provision of healthcare or adult social care or the promotion of health, which sounds great. But the next sentence is, this could include, for example, commissioning, planning, policy analysis and development, population health management, assessment of the quality of services and individuals' experience of them, workforce planning, research, etc., blah, blah. And these are all topics in the health service support framework. So it means that under the bill, NHS data could be shared for those purposes with operos owned by Centene or whoever. Now we're going to get onto the workforce, and I'm going to leave it to Alia to talk about deregulation, flexibility, and another issue, discharge to assess, and the whole issue of replacing human contact with algorithms. But I want to explain how the bill may threaten national agreements on pay terms and conditions, specifically Agenda for Change. The bill doesn't mention them. And of course, Agenda for Change covers staff who are subject to the pay review body. And these are the people who are being offered 3% after risking their lives through the pandemic. The bill does mention staff directly employed by the ICB. And these will include staff currently employed in the clinical commissioning groups. And the bill says, employees of an integrated care board are to be paid such remuneration and allowances as the board may determine. Employees of an integrated care board are to be appointed on such other terms and conditions as the board may determine. An integrated care board may pay or make provision for the payment of such pensions, allowances, or gratuities as it may determine. So Rachel Maskell MP asked about this during the second reading, and the Health Minister, Edward Argar, replied that it was not the intention that ICBs depart from Agenda for Change. Now, that's not a guarantee, but that is the tip of the iceberg, and here's why. Each ICB will be trying to cut costs because NHS England can intervene if they think the system is overspending. Staff costs are the biggest single item for all the NHS providers within the area covered by each ICB budget. The payment scheme will influence the budget allocation, but in the scheme, as I've said, the same procedure can have a different price in different areas, or if carried out by different providers, or for different patients. And that constitutes an economic pressure on the ICB to break from national agreements because costs will vary around the country. Why should they pay people the same rate everywhere if the actual price they're being awarded by the payment scheme is different? Now, back in 2012, the NHS employers in the Southwest tried to introduce local pay, and all the unions rose up to block it. But NHS England wasn't opposed to it, and they actually are on record on that. This bill will give employers the freedom to try again. What difference does it make? Well, local pay would weaken the principles of equal pay for equal work, which is the reason why Agenda for Change was brought in. But it would also drain staff away from poorly funded areas, threatening patient care. They will simply move to areas where the pay rates are higher. And unions should be taking this extremely seriously, and they should be pressing the government on these potential threats to the national agreements. Well, you'll hear more from Alia in a minute, but I just want to say in conclusion that the bill is so full of flaws that our aim must be to scrap it entirely. And we know we may lose, but even if we do lose, we have to make it clear to everyone what this is all about and why we're fighting it. We have to do that in order to lay the basis for any future strategies. So alerting all the unions, not just in the health service, is a priority. And that means seeking policy commitments at regional and national level, along with education at branch level. And we've done a model motion, which I hope Paul has put in the chat, and you might have a think about that. The other thing is that if the 3% or pay offer is rejected and health workers move into dispute, I hope that opposition to the bill can be raised alongside the pay campaign. It won't be a demand in their strike, but it's something that we can be talking to people about if they do go on strike. And I would also hope that you can find ways to raise these issues with MPs, because I suspect that many of them do not actually know the details, whether they voted for the bill or not. And the more pressure they feel from below before the third reading, the better. So that's my introduction, and I'll stop there.
Thank you very much, Greg. That's a great, if very bleak, picture that you've painted. Thank you. Okay, and I will introduce now Alia. Alia Butt is a psychotherapist and highly specialised CAMHS practitioner within the NHS, convener of NHS Staff Voices, part of Keep Our NHS Public, and a political activist working across campaigns, including Women Will Not Be Silenced. Welcome, Alia, and I'll hand over to you now.
Hello, thanks so much. So I mean, it's not going to be any less bleak, unfortunately, but I mean, I'll try my best not to depress everyone, you know, too much. Can I ask a question first? Are people here working in the NHS? So there are a few, two. Okay, lovely. All right, that helps to know. So I want to start. I mean, and I'm guessing nobody attended yesterday's rally. Paul, you did. Hi, Paul. Nice to see you. Okay, so it's going to be slightly repetitive for you, Paul, I'm afraid. I'm cheating a little bit, but I think that, you know, I sort of prepared together. So I just want to contextualize the bill a little bit and just sort of paint a bit of a picture about the past couple of years and how this bit sort of fits in after 10 years of austerity and privatisation that's been going on for a long time. It's not, the bill will not be introducing privatisation. It will certainly not be reducing privatisation, but it's been happening for a while, and I'm sure many of us have experienced that, given we all probably have had some experience of the NHS and the degradation, so the decline of the NHS and services and clinicians and resources and everything, really. And working in the NHS, it's no different. And over the past couple of years, we've seen how privatisation has been quite brazen. The government have not been particularly there hasn't been very much shame around what they're doing with the NHS and how they're really scapegoating working people in general. You know, we've seen 13, 14, maybe more than that U-turns over the past 2 years, a lot of them about health and social care, and about poverty and about feeding children who don't have enough food in the summer holidays, and lots of things that the government have had to take heed from the public, actually. But what we've also seen is people like Matt Hancock, particularly, handing out these contracts to his friends. You know, it's called cronyism, it's blatant corruption, and it's just handing taxpayer money to private companies, more often than not, completely incapable of doing the jobs they are paid huge amounts of money to do, completely incapable, making a huge mess. I mean, the track and trace system, I think it's 37 billion and another 15 billion going into it. So that's a lot of money that could have been put to really good use. It's obviously just leaking through these other companies. And as you possibly know, privatization, it takes money out of the NHS, money that would usually be recycled within the NHS. So that's kind of the main thing, actually, I think. So more recently, we've heard about the national insurance tax rise. I think that's been very difficult to hear about and process, as we're aware that it will significantly disadvantage working people, and very wealthy people, for example, will not be affected by this, which is just really quite a painful reality, and I think it really encapsulates a lot of the difficulties that people are facing and what the government is up to. The money is apparently going into the NHS to tackle waiting lists, it's going into social care, but we're aware that money going into the NHS doesn't always mean that that money will be seen by clinicians or by patients, so it doesn't necessarily result in it actually being used to improve services or patient care. It will likely be squandered very irresponsibly. MPs and people in Sajid Javid, for example, was speaking about it. There's no plan or no targets as to how this money will be used, which probably means it won't go where we expect it to go. It will probably go into the coffers of people who don't need it, or the pockets of people who really don't deserve it. So that's kind of, I don't know, I feel like that's kind of really quite connected to the NHS. And I think you know, yesterday I was talking about the comparison with universal credit monthly. You know, the amount that people get for a month is, I think, £323, which is the same as what you get in the House of Lords for basically signing in. They've now had an above inflation rise in that particular daily rate that they get for doing absolutely nothing. So, you know, the money is there, there's money there. They're telling us there's no money. They're telling us that there's not enough money for a pay rise. This 3% pay rise is obviously not going to make much of a difference. It's certainly not going to take us back to where we were 10 years ago, if you know what I mean. We are still going to be earning less in the NHS than we did 10 years ago. So it's not restorative. It's certainly not going to encourage people to join the NHS. We've got thousands of vacancies. We had more than 100,000 vacancies before the pandemic, and the pandemic, obviously, we had the highest number of health worker deaths in the whole of Europe. So we've fared quite badly. So yeah, I suppose the government have made it very clear that their priorities are not working people, and possibly that is why the NHS is being so strategically destroyed, and it's not doing very well. We're hearing about the upcoming winter crisis, which we hear about every year, and it does get worse every year in the NHS. But I also feel it's important to remind us that, you know, the winter crisis, the maternity crisis, bed crisis, mental health crisis, emergency service crisis, wheelchair crisis, all of these crises have been set up by the government. These crises have been created by privatization, austerity, etc. And you know, the point is, I think, to destabilize infrastructure, social infrastructure, so that it's not really capable. And then when there is a crisis, it completely crumbles, and then privatization feels far more appealing, and that's how the public are won over and things. So I think that's where we currently are. This bill, as Greg has mentioned, it's a really scary prospect. And I think that the main points that, and Greg has already said this, but I'm just going to kind of phrase it maybe slightly differently, but it's going to be much easier for private companies to be awarded contracts with no competition. So, like, you know, even in the past year or two, where people like Matt Hancock, I use this example because it's for all of us to see, you know, he was giving contracts to people on WhatsApp who were texting him and things like this, you know, neighbours, friends, etc. But even in those instances, these contracts were required to be out for competition. So there were other people involved, there are other people going for the contracts, other companies. That is not going to be a necessity anymore, and it will be much easier for corruption to take place, quite frankly. And I think, you know, and the other point that I think Greg's already made it as well, that private companies will be able to sit on these ICS boards, and therefore they will be able to decide how money is spent, which is obviously a conflict of interest, but it's also really worrying because they don't have a clue what they're doing. They're not health professionals. They're not interested in actually doing things in an economic way. It's very wasteful. They end up wasting a lot of money and not doing the jobs properly. So, you know, that's obviously going to be really, really worrying. In the bill, there's nothing specifically really about mental health services. And I think that's indicative of the real the kind of, what's the word? Just, it's not really cared about mental health and, you know, the public even, but very much the bureaucracy, they don't see it as important as physical health. So it's not really featured in there. But mental health services are obviously going to be affected by the continued dismantling. Now, we have millions of people turned away from mental health services every year, millions, lots and lots of people. 2/3 of young people who are referred to CAN services are, you know, refused treatment. We have children drinking bleach to try and get into services. We have children, you know, I have had cases come to me with young people, you know, I had to try and kill myself, otherwise I couldn't get a therapist. You know, this is what we're getting, referrals in from A&E, and it's a total horror show really in mental health services. So I'm just trying to, how long do I have to speak, Juliet? Can I just ask, because there's so much that I could...
It's meant to be 15 minutes, Alia. You could, another 5 minutes or so.
Okay, great.
Right.
I think I've just been going on and on about sort of privatisation in general. But actually, Greg, you covered quite a lot. And I think that the main worries, I guess, that I had as a clinician were around deregulation. I think it will result in a seriously compromised patient care, you know, disbanding regulatory bodies that oversee the ethical and practical conduct, as well as the ability and the training of clinicians, is obviously going to compromise care. I think, you know, in our line of work in particular, it's quite a worry. And it's not that nurses don't need heaps of training, and, you know, if they're not trained properly and they don't do, you know, a certain procedure correctly, people die. But I think it's really quite similar in our line of work. You know, if you don't pick up on something on the phone in an assessment, somebody can be in real danger. And I think, you know, I've seen it myself working in the NHS over the past, you know, 5-10 years. When I started working in neurodevelopmental pediatrics, so it's basically young people who are struggling with ASD or social communication, or, you know, something more complicated than that. We're trying to figure that out. I was taken on as an assistant psychologist there before I qualified as a psychotherapist, but I was doing band 7 work. I don't know if that makes sense to anyone. I was barely a band 4. I was doing band 7 work. So that's work that people far better paid than me and far better trained than me should have been doing. And this isn't that long ago, but the fact that I was willing to do it, the fact that I was capable, the fact that I had energy, the fact that I wasn't making mistakes, it was totally fine for them to let me do it, to the point that they actually fired the band 7 who was employed to do that work and just added it to my job role. And I did it because, you know, you think I want to do well in my career, you do it. So there is not going to be people saying, no, we shouldn't be doing these jobs. That's not going to happen. I mean, eventually I did do that, but it took a lot of courage and a lot of kind of, you know, it was very hard, basically. I had to leave that trust eventually. But, you know, that situation is going to be far worse, or the situation is going to be far worse for mental health services. I myself requested, I mean, I've had a really bad experience as a patient in mental health services. I never really got the support that I needed growing up, probably why I'm a specialist in CANS now. But, you know, recently I thought, God, I really need some help actually. So I did get in touch, and I don't know, maybe I was just trying to check the system, work the system. I had the worst assessment on the phone. I mean, to the point that I was almost in tears, and not because of my predicament, because of just the very bad treatment I got. And, you know, Greg mentioned that there's talk of changing the services that we are providing. And I think COVID has made it so that we are having to use things like the telephone to provide services. And I think they're just getting very, very cozy with that. It saves money. It means there's less office space, less people taking space in buildings. It really is that, I don't know, without swearing, it really is that bad. That they are just trying to minimize everything. I mean, we know from what is offered in the NHS, 6 sessions of CBT for people who are in excruciating psychological pain, grief, it's just completely inadequate. And it's really, really, really going to get much worse. So yeah, I mean, I could keep going forever, I guess, but please do support the campaigns against this bill and encourage people to do so. It's going to be so bad. And, you know, poverty is definitely, we've had 700,000 people plunge into poverty. The universal credit uplift that's going to be taken off October 6th is going to plunge thousands more into poverty. We're going to have a lot more demand for what we do. But it's not going to be manageable. So we need the NHS. We really need the NHS, and we need to, I mean, I think we're going to need a real campaign for adult services. Just don't have, there's too much else going on at the moment to even focus on that. But there's a lot of work to be done, I think, I guess. But I'll stop there.
Thank you very much, Alia. Thank you for your honest and open. Andy, would you like? Yeah, go ahead.
I'll kick things off. It's a bit of a contribution and a question as well, and it's maybe Alia might be able to answer this more than Greg, but whoever. It's on deregulation, and reading I think it's the document Working Together in Health, where they talk about professional deregulation and that. And the powers that they're going to give the Secretary of State just to abolish regulatory bodies if they decide to. But psychotherapy and counselling as a title is not regulated. So you would think, well, what does that have to do with us, sort of thing, you know, because we've got a membership body, but we've just got psychotherapists and counsellors and they're not regulated. Well, my question is that, and my fear is that what will happen in the NHS with this bill, if they deregulate regulators, that will be a downplaying and a de-skilling of the roles that those bodies were regulating. So that would be the same for counsellors and psychotherapists. So you might see as a rippling knock-on effect that the role of a counsellor and a psychotherapist will be downplayed, so that the training that we've gone through won't be necessary anymore. So you'll have people, I don't know, doing 2 or 3 weeks courses and then being given the role of providing mental health services, counselling, as we would. And that would ripple through to the third sector and through to the private sector as well. So if people feel as if, well, I don't work in the NHS, it doesn't affect me, I think it's got huge rippling effect through the whole of the psychotherapy world. And we could end up being completely marginalised and overtrained and then underworked as well. I don't know what you think about that, Alia, but that's my thoughts on it.
Well, it's interesting, isn't it? Because even at the moment, I don't know if people agree with me, I imagine you will, but even at the moment, we have lots of very undertrained therapists going around calling themselves psychotherapists and counsellors with no therapy, with no supervision. And, you know, that's kind of, oh yeah, it's very frustrating. But I suppose we have the UKCP, we have the BACP, and those are still there, and that kind of keeps me a little bit calm. But with regards to the NHS now, there are not very many psychotherapy posts in the NHS, few and far between. I don't know if you guys have come across very many, but there aren't very many. So generally at the moment, Andy, it's more psychologists, it's more psychological well-being practitioners, and you know, this therapist and that therapist, and all kinds of new people with very different training to us anyway, doing things that we could probably do very differently, but we're not given that opportunity because psychotherapy is not seen in the NHS in the same way as psychology. It's seen as less prestigious, I guess, and I don't know if that is because, you know, I guess psychiatry, they have a Royal College, don't they? They're protected. In the NHS, they get a whole clinic room. I mean, we get nothing. So even at the moment, psychotherapy is not seen in the way that you would hope in the NHS. And private practice is where I mean, I'm sorry to say, actual psychotherapy does not take place in the NHS. It's not possible. We don't have the time, we don't have we're not allowed to have open-ended. I mean, I'm very lucky that I work in an adult service that offers 1 year of psychodynamic. It has to be psychodynamic. I'm an existential therapist, but I work psychodynamically because I have to, and I have done for a long time, and luckily they're quite similar, and I enjoy it and I enjoy learning about it. But it's already totally not so, you know, it's already not really giving psychotherapy in the NHS. So I guess, I don't know if that helps a little bit to sort of understand what's going on already. And yeah, I mean, I'm really worried, really quite worried.
Can I put Diana's question forward, which Diana says, please can you give an example of how mental health services might work under the new bill? Just the PCU, we've actually made a comparison with the NHS Act and the Mental Health Bill as well. Well, sorry, the NHS Bill and the Mental Health Bill, which you can find. In fact, I think we're going to try and post it on the chat site so you can actually read it yourself if you haven't seen it already. But I'm just wondering whether Alia or Greg got anything to say about that. That makes sense.
Well, I guess at the moment we don't know, and there's not very much stipulated as far as I know. So please correct me if I'm wrong, anybody. But what I can say with confidence is that given those who will be making the decisions of how money is spent, is not going to, you know, it's not going to be clinicians anymore. It's not going to be people with experience and expertise. It's going to be people, you know, it's going to be bureaucrats, basically. It's going to be people on the sidelines who don't really understand. So, I mean, it's not clear what's going to happen, but it's very likely that they will be, you know, downgraded. There will be less clinicians. I think everything is just going to look far, you know, and one thing that's quite strange in terms of funding is that every area is given a certain amount of money, that it's not about what they need, and it's not about the services. It's just very much one shoe fits all, which is obviously not practical. So, I mean, Greg, I mean, I don't know if you have anything to add, Greg, but it's not clear. I think it's just going to be far worse than it is at the moment. We know that mental health services across the country have been closed by 2/3 in the past 10 years. And I mean, that's huge amounts of services. It's only going to get worse, I think, really.
Could I say something about that?
Sorry, there's something I did want to come in on, but is that okay?
Yes, go on, Greg, and then Paul, do you want to go afterwards?
Yeah, fine.
Yeah.
We also have a question in the chat.
Yeah,
Yes.
we'll take that in a bit, Milton, thanks. But go on, Greg, yes.
Okay, I can't answer the question that you've just been talking about, but I want to say something about the deregulation issue, because I want to tell you what the government said about this in the white paper, where they were a bit more forthcoming about why they thought it was appropriate to deregulate specific job roles. And this is very revealing. What they said is that there are job roles which currently require regulation to protect the public, but with changes in technology, that may not be required in future. Now, to me, what that means is that they think that if somebody is using a computer or a computer program, then they don't require the same level of regulation. And I think that this is both wrong and extremely dangerous for several reasons. The first obvious reason is that computers fail. And so if you have somebody who's completely reliant on a computer program and the program fails and they don't then know what to do, that's a dangerous situation. But the second thing is that even if the computer is working and there's no virus and, and the power's on, the kind of thing they're talking about are expert systems where, artificial intelligence or some kind of expert program is looking at the patient notes and saying, well, this is the situation and this is what you should do. Now, even if those expert systems are written by real experts, these are the sort of things that have to be constantly refined. And they have to come up against the hard reality of what actually is happening. And then you find out whether this thing works or not. Well, you can't do that if the person using the program doesn't actually know any more than what the program says. It only works if the person actually knows what's going on and they can say, okay, thanks very much for your reading of this, but you're wrong. Your program's wrong on this occasion. And so what they're doing is they're trying to dilute the job role, make it more reliant on the technology, less able to cope in a situation where the technology fails. But the point to this is it's cheaper. And that's what Alia was talking about. And her story is very pertinent here, that she was, suckered into acting way above her competence and then eventually kind of walked out of that. But that's exactly what they're going to want to do, is to say you don't need to be a band 7 because you've got a computer program. Band 4 can operate the computer program. That's it. So that's the thinking, and they were explicit about it in the white paper.
Thank you, Greg. Yes, it's incredibly dangerous, isn't it, as well, because you're dealing with people's lives. Yeah. Okay, Paul, do you want to ask your question? Paul?
Yeah, I just wanted to make a comment because I think psychotherapy in the NHS has already been deregulated and de-skilled, and it's called IAPT. It's an extraordinary kind of success on the part of IAPT to more or less clear relational psychotherapy out of the NHS, and the third sector has followed because of the funding from the government being dependent on following the kind of evidence-based narrative between NICE, CBT and IAPT and so on. I think the future is really grim for any kind of psychotherapy. Far less than 50% of IAPT at the moment is actually person to person, people sitting in a room doing therapy together. There's all kinds of low intensity stuff that's called therapy. It's not talking therapy at all. And I think the digitalization of IAPT and so-called talking therapies is going to massively increase. In my area in Tower Hamlets, I've already seen the way UCL are bringing in partner companies to introduce more and more kind of apps and software into the mental health sector. So we've led the way in mental health, has led the way in privatization, de-skilling, destructuring. That's going to get much worse. I think that is going to get much worse unless we do something about it. And that's partly why we're starting this campaign called UACT, which I've put the link to the website and the statement in the chat. So have a look if you're interested.
Thank you, Paul. Greg, Alia, did you want to say anything to what Paul had to say?
No, just, yeah, I completely agree, Paul. Thank you for adding that. I'd hate to work in IAPT. It's everything that we hate, really. And I wasn't aware that 50% wasn't even in person, but I'm really not surprised. So thank you for that. And I would love to get involved in the campaign, so I'll check it out.
Yeah, please do, Alia. Please do, Alia. Get involved.
Any more questions?
There's no more in the chat, apart from Sasha thinks it's therapy delivered by drones. Well, in some way, there's some truth in that. It's kind of, there's a drone kind of analogy there somewhere, I think, somehow, because it's just targeted and in a way which is quite crude. So.
I could throw something else into this if there's no question at the moment.
Go on, Greg.
Yeah.
Yes.
Okay. I'm sure Alia will want to say something about this. One of the things the bill does is it removes the clause of the Social Care Act, which of the Care Act, which requires a social care needs assessment before somebody is discharged from hospital. And to me, as a non-clinician, this seems incredibly dangerous. And I'm going to pass over to Alia in a second, but all I'll say is you can imagine people being discharged who are A, not able to look after themselves in the new situation they land in, and B, they may provoke all sorts of crises if they're being looked after by their family, within the family, where people can't actually cope with this. And then there's all sorts of mutual recriminations about the fact that they can't do it. So it sounds to me like the consequences of just dumping people out of the hospital without knowing whether they can cope, which is explicitly what this is about, is going to be a disaster.
Yeah, I guess just to add, I mean, the government has provided an additional 588 million for this, and the funding is to help cover the cost of recovery and support service and rehab outside of the hospital setting once they're discharged from hospital. However, as Greg said, you know, and as I've already said, this money, we don't know where it's going to really go, but it's very unlikely that it will go to patient care. And, you know, these people who are not going to be assessed, they're going to be discharged. We don't know if they're going to have anyone to help them. We don't, you know, this is a huge undertaking. It's a big part of patient care, as I'm sure many of you are aware. The rehab afterwards, what happens afterwards. You can fix somebody up, you know, if you just, you know, it doesn't mean anything really, particularly for those who are a bit older. Recovery is so important for life, and lots of people will die because of this. I mean, I'm saying that as if it's not really serious, but it is going to mean thousands of people are going to lose their lives, and they're very explicit that they do not want this to happen. So it expects to keep hospital beds free for patients with the most pressing needs, and we know that there's a huge bed crisis. You know, when I started campaigning really quite vehemently, the first thing we did was this big thing about hospital beds, and 5,549 people died that past year. I think it was 2018 on hospital beds, just waiting on the beds. It is a big crisis, but it's like, you know, it's compromising many other lives for beds. So it's not necessarily very intuitive, even though it seems intuitive, it's not. And it's a discharge to assess, as Greg said, which is, again, incredibly counterintuitive. You must assess before you discharge. It's not good healthcare. It's certainly not good social care. And it's going to be pushing patients into the community services and primary care services, which will not be receiving these funds. They won't get the money for it. They will just get the backlog, or you know, they'll get the additional work. So that I guess the problem is that you're going to be fine to leave, but degenerative conditions aside, you know, people degenerate if they're not properly looked after when they're on the mend. So yeah, I mean, I keep thinking, who's going to look after them? Like, who's going to do, you know, if you're not even finding out if these people have family members, can you imagine discharging someone who's just had a stroke? Oh my God, it makes me really quite scared, because that's what the reality is. And these decisions should be made by clinicians and families. They're not even going to be made by anybody with any real experience. It's going to be made by people who are not involved, from the sidelines, very much the money handlers, who often work for profit and not people. And the last thing on it is the criteria for discharge may ignore many other valid reasons for staying in hospital longer, such as stress, ill health among carers. So, you know, carers might be really unwell, doesn't matter. Severe persistent diarrhea, vomiting or acute metabolic disturbance. And this one is quite a killer, I think. I mean, sorry to use that word, but an infectious disease that could infect others in the care home and community hospital. We've seen the biggest number of excess deaths because of the social care fiasco scandal, actually. Oh, Matt Hancock's going to ring fence around social care. He's just encouraged many, many people's deaths. And that is just going to be continued if this legislation is allowed to go ahead.
Thank you. Gavin, you want to say something?
Well, I was just going to say that my view on the 1.25% increase in the national insurance is, and it's kind of reflecting really what we're saying. The way I see it, it's just us as taxpayers, those paying national insurance, which is most people, another way of sucking money into the private system, the shareholders. I mean, I don't see, it's just how much this 1.25% is going to go for care. Obviously, hopefully some will go for wages, I think that's been said, but how much is really of this, our taxpayer money, our taxpayers, what we're paying, is actually going to be sucked up into all these American companies, shareholders, and what we've been talking about today. So that's just my overall thought on this, which keeps them going around my head, because I can see it happening, and how pleased a lot of MPs are that this is happening. I'm not happy, they may be on the face of it not happy that there's a tax increase, but on the other hand, a lot are possibly quite happy they can see some of them getting some of their this money into their companies and their friends' companies as well. I mean, that's kind of my sense on this. Paul's put some questions and into these chats. So I mean, Paul, do you want to come in next and say what you've written in the chat? Or did you want to say anything on that?
I just wondered, I thought it was really interesting yesterday, the point about Section 75. I know Greg touched it, but I think there's something really important about realizing that, you know, the government will spin it as removing Section 75 as somehow stopping privatization. It will do exactly the opposite. It will make put bidding in the hands of the ICBs, the integrated care boards. I just wonder if you had thoughts on that. But also, there are far more physician and nurse associates on the way, I think, around, you know, deregulation. So I wonder if you have thoughts on that.
I can comment on both of those if you want. Yeah. Okay. Well, yes, I think I did say some of this, but the point is this. What they're saying is that contracts won't necessarily have to go out to tender. You know, that some of the current situation under Section 75 is that any contract worth more than £615,000 or whatever has to be put out to tender, and that's going to be abolished. But that isn't the end of privatization. It simply means that the contracts can be handed out without going to tender. And one of the features of this is that if they simply wanted to give the contract to an NHS organization, they don't have to get rid of the Public Contracts Regulations 2015, because that option was already there. So the whole purpose of doing this is to be able to hand the contracts out to non-NHS organizations. That's the point to it. So another feature of this is that PCR 2015 does actually include provisions where the commissioner can require It's an option, but they can require adherence to all sorts of legislation, international legislation on labor rights, which are basically the ILO conventions, but also environmental and social protections. That's an option within PCR 2015. So getting rid of PCR 2015 might sound like getting rid of privatization, but what it's actually getting rid of is the protections. Another option in PCR 2015 is to actually look at the track record of the bidder. So if you get rid of that, what they're saying is all we're going to be able to look at is the bid, not who these people are and what they've done in the past. So that goes. So it's a massive kind of deregulation, and it's being spun as the end of privatization, which it isn't. Now, the other point that you raised was about downbanding, basically, and I think that's all part of the flexibility that NHS England is trying to bring in. Now that's, as far as I know, that's not explicit in the bill, but it is very explicit in the guidance that NHS England has been issuing. And they've done it again and again and again. And what they want is for people to be able to work for different employers. You think you have a contract in one place, but then they say, oh, well, no, you're working in another place for another employer. And here's a passport, which allows you to move from one employer to another, and not even necessarily within the same integrated care system. You might have to move over to another one. And that's because the boundaries don't always match with the local authority boundaries and so on. Now, what does that actually mean for union organization? The way you organize a union is you're in the same place talking to the same people for long enough to be able to have a conversation and start explaining why you need to get organized. Well, if every other day you're moving to a different place, it's really difficult to do that. And it's obviously, even without the union side of it, it's incredibly demoralizing for the worker, because part of the way you cope with the stress of this job is through the support that you get from people who actually are your team. But if you haven't got a team anymore, you're just being reassigned every other week, that destroys that. And it's obviously bad for the environment as well if people are traveling all the time. So there's all sorts of ways in which this flexibility that they're bringing in undermines the working conditions and undermines the possibility of organizing a union. So that's why they're doing it, of course.
Yeah, the only thing I would add is in terms of Section 75, I think the example I used, which might have got lost because there's so much that we're saying here, is that, you know, these tenders that Matt Hancock is so easily giving out to people are going to be much less scrutinized, and there will be far less transparency than there has been. So that's kind of the long and short of it, as far as I can tell. With regards to, I mean, again, even in my experience, Paul, just your second point, when the example I used about working as a band 4 and a band 7, I said, I had to make quite a bit of fuss saying, look, what am I doing? I'm basically doing what a clinical psychologist does. So they created a post, and they've been doing this for a long time. They created a post called Senior Assistant Psychologist, and that is what they're doing. They're making assistants out of clinicians without the prestige, without the badge. That's basically what they're doing. They're going to keep doing it. And of course, I wasn't a clinical psychologist. I hadn't trained in it. I was just doing what they were doing. So, I mean, that is what we're going to be seeing more of. I think that's what you're talking about. I'm not sure, but I think so. I'm going to have to go very soon, everybody. I'm sorry about that. And I hope it doesn't, I hope that's okay.
Thanks so much for your
Alia, before you go, just a question from me. Are the unions doing enough, do you think?
The unions aren't doing enough, and we are putting pressure on the unions. I think all the unions have said no to the pay offer, or they've suggested to their to the workers that they represent that they should reject the 3%, and that's good of them. But they're not doing very much else. I'm finding it hard to even know which union deserves my support and money and passion, to be completely honest. And it's a struggle because I really want to find somewhere where I can. And at the moment it's Unite or Unison, both of which are not. I mean, I feel like, Juliet, there are workers within the unions that are really doing a lot for the when I say workers, I mean union reps, who are doing a lot for. So for example, in Unite, there's a Unite rep who's doing some amazing work across BARTs, and I think that's 5 hospitals, and the cleaners, the out-of-house cleaners are being brought in-house. They're working on their pay, and there's lots of really important campaigns going on there that's really building morale. But other than these kind of isolated campaigns, there's not enough going on, and I don't really know how we can work around that. But I think there has to be, I mean, I'm part of Key Franchise Public, which doesn't really put pressure on unions, but we have to do something because we need that help, you know, as clinicians.
Yeah. Thank you.
Could I just add a final comment before? I think at the moment, mental health is not represented on the IC boards the way it's set up at the moment. There's no mention of representation from the mental health sector, which I think we could try and do something about. But it is very interesting that it's just not recognized in this ICS plan at the moment.
And maybe that is something that we need to pick up on, because I've been thinking about it, sorry to go slightly off the cuff, for a while now. And I mentioned it earlier that we need to do something about adult mental health. And I know children are they're struggling, but the adult mental health services in the NHS are far worse in terms of what they provide. Paul's kind of spoken about IAPT and how it's completely, it's not really mental health support at all. It's more like box ticking, and you might as well be doing like a Myers-Briggs personality test. It's just total nonsense, and we have to do something really. And maybe this is an opportunity to think about how we can bring adult mental health to the fore by saying it's not even, you haven't even thought to bloody put it in what, you know, what is this?
Can I just, it's Prudencia Wood here speaking. Hi everyone. Thank you for all that's been shared so far. I would like to just throw something in. I'm coming from the perspective of being a social worker, but I'm also training to become a systemic psychotherapist. So obviously I've got a vested interest here. So I feel like I'm right at the other end of the spectrum. You guys sound like you're much way down the other end. But I wonder, has anyone thought of harnessing support from training organizations? Because you've got a load of trainees going through this system, this conveyor belt of learning. And I don't know that many, we certainly didn't know. If I didn't come here tonight, I wouldn't know how grave the situation is out there. I wouldn't have a sense of that. No one's talking about that. But I'm sure that my peers and people in other establishments would want to know about this and what's going on. So I'm just curious about whether there's been any sort of thought about how to harness support from trainees, newly qualified, all kinds of other people, really.
Evan, did you want to speak to that? You've got your hand raised, or are you just wanting to ask a question?
Who me?
Yes.
Yes, I think so. Well, we wondered about training institutions before, that they're really in it mainly for the money, because they need, the more people that get into training, of course, they're going to keep the courses going and get money from it. But however, also so much, and this is all part of the disparity in mental health, how if you can't afford it, you more likely to go into IAPT, and if you can afford it, then you go into private practice. And that's the real irony, because you need money to pay usually for private practice by definition. So a lot of people training have to go into private practice, which I do low cost therapy, but often you can pay £100 to £200 an hour for private therapy, and sometimes even more. And not ordinary people can afford that. And that's the real dilemma as to when you're training, what do you do? It's very hard to get a psychotherapy job, as has been said, or anything meaningful in the NHS and the other bodies, schools and so on. So that's the dilemma we have, is what to do when we're trained, where to go. And this is what Paul means by the discrepancy, by that mental health is leading the deregulation of the NHS, and it has been for some time. So that's just my thoughts.
Paul, do you want to come in? And in fact, I'm just going to allow people to come in as they wish now, I think.
Yeah.
Okay. Well, Prudencia, what I'd say is that the private psychotherapy section, independent section, is a fundamentally neoliberal project in the way that it's organized by the trainings and by the member, the professional member organizations, UKCP, BACP, and the British Psychoanalytic Council, in the sense that they have, those organizations are very, very sort of undemocratic. They're basically trying to get onto the kind of power tables of government and sort of funding. They're trying to get into IAPT and so on. But there are, and many of us fought against, the politics of these organizations for decades. There are now, I'd say, look at psychotherapists and counselors for social responsibility. There are trainees there who are trying to organize. There are trainees in Counselling Together UK, which is a newish organization. It's got 5,000 members, and it's very active around the politics of training and so on. So there are things happening. There's a lot on Twitter that never used to be on Twitter. A lot of therapists and clients talking about the politics of psychotherapy on Twitter at the moment. So I think it's a matter of chasing things up. If you want to get in touch with me for more support, yeah, I'd be very happy to talk about it.
Yeah, I'll do that. I'll definitely do that. Because there are all kinds of things here, all kinds of things are popping up for me as I'm listening, and I'm like, well, when we go off and do our training, we're going into we're going into hospitals, we're working in clinics, we're working with the public in those places. We're not going into private spaces, as it were. So it's almost as if we're sort of, we're encouraged to sort of cut our teeth almost, or practice on the unsuspecting members of the public, and then we're supposed to go off and work privately, so the same public can't afford us then further on down the line. That's a madness, pardon the pun.
There's lots of madness in the question, definitely. Yeah. Can I mention?
I'm a little bit angry now.
Yeah, no, upset. Yeah. Yeah. I think a lot of us are, and have been for ages, and we really have failed to tackle the whole kind of IAP scam, which has now been going from 2006. It's terrible.
Wow. Wow.
Can I mention the Free Psychotherapy Network for people who don't know it, which is an organization of private therapists, independent psychotherapists who are offering free sessions to people on low incomes and on the DWP. I mean, there aren't many of us, but I think it's a very important symbolic project, around how things need to change. And that's a message to psychotherapists as well as to government and funding and stuff like that. Yeah.
Brilliant.
Just if I can just take it to another area, and I think it's important to talk about the cost, because in tonight's discussion, several people have talked about taxpayers' money, and as if we pay in to the government our taxes and then they pay it out for services, when in actual fact that's a myth. And it's been a myth since 1972, when we came up roughly off the gold standard. Or we came off before then, but when we became a sovereign state where we could produce our own money. And I think the economics is important, because when I've done stalls locally for the NHS as part of this campaign and all the rest of it, one of the questions that's asked is, well, how are we going to pay for it? You know, and can we afford it? And all those sort of questions. And you get really kind of hung up if you try to say, well, we'll tax the rich, or we'll get it from here, or we'll get it from there, when in actual fact, the answer is really simple. And it takes a bit to get your head round, but there is no correlation whatsoever between taxation and services and paying for services. They do not connect in any way whatsoever. Services are paid for by the government, and taxes are used for different means. Now that's totally against the myth that's been peddled for years by mainstream economists. But that is there's a paradigm change taking place in economics, where they're all accepting in sovereign states like UK, Australia, America, that if you print your own money, then you don't need to borrow it, and you don't need to raise taxes to spend it. You can print it. And it's called modern money theory, though it's not a theory. You go on the Bank of England and they'll show you how they do it. And so in actual fact, we don't need to worry about the cost, because as Alia said, they spent 37 billion on track and trace. That didn't come from taxation, that came from a keystroke. They put 37 billion into the computer, clicked the keystroke, and it went to the organizations. And that's, I know it sounds difficult to get your head round. And a way to be able to do that is to have a look at the book written by Stephanie Kelton called The Deficit Myth. Very good book, or Reclaim the State by Professor Bill, who's the founder of modern money theory. And there is a local organization, national organization called GIMS. And there's lots on YouTube as well that'll explain it far better than I can. And it's taken me a while to get my head around it, but you know, cost is not a barrier to providing healthcare for all, free at the point of use. It's absolutely easy to do, and the government could do it tomorrow. So you don't get sucked into this idea that there's a cost implication, and don't get sucked into the idea of, well, they're giving so much money to the NHS, so how much more should they give to mental health because it's a fixed sum. It isn't a fixed sum. It will be when they bring in these 42 different groups, because they'll just give them a fixed amount of money, but the government can produce as much money as it likes, and it doesn't cause inflation either, which is another issue, but I won't go into that. It's a huge topic, and I'm not an economic guru by any stretch of the imagination, but I understand this, and I would say to people, just have a little look on YouTube on modern money theory, Professor Bill, or Stephanie Kelton's book, Deficit Myth. It's really worth a read.
And Andy, you've got some points about how to keep points for action, haven't you?
Oh, sorry. Yeah. What I did, I put into the chat what we can do afterwards, and that is, you know, join, keep our NHS public, get involved locally, write to your MP, pass resolutions in your parties that you're in. You know, set up a stall, talk to others, and I'm hopeful that the PCU will do a press release to say that they support the motion that Greg's put forward there, and that in doing that, you know, if people can just get out there and get active, do whatever you can, because it's a bottom-up movement rather than a top-down from the unions. It's us, the people, that have got to do the work. As we said in the Eventbrite, you know, it's the NHS will only be there as long as there's people there to fight for it, and that's what we've got to do. And any bit you do is good.
Okay. Well, Greg, did you want to say something? Yeah, go ahead.
Yeah, I wanted to comment on the fact that they didn't hesitate to bail out the banks in 2008. And then they turned to McKinsey and said, how are we going to get the money back? And McKinsey outlined the 3 ways that they could cut the NHS in order to get some of the money back. So they are concerned about getting the money back, but they weren't concerned about spending it. As you said, I mean, I think the figures are slightly different, but it doesn't matter. They did hand out billions during COVID, and they handed them out on the terms they wanted to hand them out on. But the other thing I wanted to say is this, and I'm not an economist, but I am familiar with the fact that the multiplier for the NHS is high. It's something like 3 times as much money comes back as a result of investing in the NHS as what you actually spend on it, because of the improvements in the health of people and their ability to actually function and live and spend money that goes into the economy and so on. And that's the opposite of the defense industry, which doesn't have a multiplier, you know, or it has a low multiplier. So the idea that they can't afford to spend money on the NHS is just crackers in their own terms. In the terms of bourgeois economics, it's crackers. So I'm not disagreeing with what Andy said, but I think there's that dimension to it as well. In terms of what people can do, yeah, fine, all the suggestions that you made. I hope people will get involved with KONP in your own locality. But simply talking to people and alerting them to what is actually going on here is a very positive contribution wherever you are. You know, people basically do not know how serious this situation is. And so that's an argument which, if you can mobilize it, needs to be put to MPs of all persuasions. Because first of all, on the Labour side, there's no guarantee of how far Labour will go in opposing this. You know, the track record is pretty poor. So they need to be hearing from people that, you know, we really want this opposition to stick. But also the Tories, you know, have got away with this because they haven't had to face people screaming at them about what is happening to them. And I think, you know, you may be in a uniquely strong position to make that argument if any of you are in Tory constituencies. I'm in Liverpool, there aren't any Tory MPs in Liverpool. And the experience that we had during the election, the general election, was very interesting. You didn't have to talk to people in Liverpool because they already knew you were wasting your time canvassing here. But if you went to Southport or to Warrington, it was a different story. And people did not believe that the NHS was facing privatization. In fact, they simply said to me, that's what Labour said, therefore it's a lie. Now, it's hard to argue with that kind of logic, but the point is they don't see what's coming, and we do. So the more you can do to explain to people what this juggernaut is, the better. The last thing I'd say would be useful is I think that it might be worth trying to write something for the KONP website about the situation in psychotherapy and IAPT and privatization and all of that. So I'd ask you to consider writing something and to get in touch with KONP nationally and see if they want an article. I think that potentially could be very interesting.
Thank you, Greg. Milton, you and Gavin, should we perhaps finish with you? You've got your hands raised, both.
Oh, I am speaking as a PCU member, not the admin. I had a placement in the NHS for 3 years, and I think unpaid. And I think this campaign as well need to think that's non-free work. Everyone have to be paid. The monies come and they're being used for something else, or you have a management or CEOs of charities getting a lot of money, and the counselors and psychotherapists is unpaid. This is unfair, and it's not good for training as well.
Yeah, thank you, Milton. Yeah, I think as services are downgraded, there's also a huge amount of use of trainees for free work in the NHS. Yeah, and I think yeah, I think unions need to develop a negotiating platform and a much stronger presence within what's happening. Yeah. And Gavin?
Yeah, I mean, I'm taking up points made. I do talk to people, my friends, but I want to keep them as friends because I don't go ranting about all this, because otherwise I won't be friends left. However, I do bring in what's going on in the NHS, and people know because they're paying themselves. I mean, you have to pay if you want. I'm talking about ears. I mean, I had my ears. You don't really have them syringed anymore. You have them evacuated. You have them suctioned rather. And I went to Specsavers to have my ears suctioned, and it's a much safer kind of way of doing it actually. And it cost me £50 because it's very difficult to actually get them syringed. Some surgeries do not syringe ears anymore. Therefore, the point is, a lot of people I talk to, friends I talk to, they seem to know this is happening, and they seem quite helpless as to what to do. Of course, they know that I belong to KOMP. I encourage them to get active, but it's, I don't know, there's a lot of we're sedated as the public. There's this book by James Davis called Sedated about how we are sedated, and that's why we don't protest. Well, apart from a lot of people here, and a lot of people do protest, because it's just happening by stealth. The fact that we're having to pay for private therapy, pay for our ears to be syringed. A relative had to pay £14,000 for her knee to be replaced, and this is happening. It's by stealth. If you want the better treatment, it's more and more we have to pay for it. And yeah, well, that's just some more thoughts as to how it's going. It's not good.
Okay. Any final thoughts, Greg, before we close this meeting? I want to say that you know, we will try and share this video far and wide, and everything that we've gleaned from it. Yeah.
Yeah, okay. Am I unmuted now? Yeah, okay. Yes, thank you for doing this. It was a good thing to do, and I'm also grateful to Andy for suggesting that Alia Butt be invited, because I was daunted by the idea that you wanted me to talk about the implications for psychotherapy and counseling, which I can't do. So it was great that she got involved in this, and I hope she does work with you on the campaign. The one thing we know about this government is that they are not really in control. They have a majority, but they have had to carry out U-turns. And we don't know how this situation is going to develop because of the timing. They've tried to do this in such a way that they can declare victory over COVID and then say, we'll apply the lessons of COVID to restructure the NHS. The trouble with that gamble is that COVID doesn't look like a victory at all. And it's just imagine where we're going to be in November when this comes to the third reading. We're going to be going into the winter crisis in any case, but we're probably going to be going into another COVID crisis because COVID hasn't gone away. The levels now are something like 30 times higher than they were last summer, and we're going into the autumn period. So I think there will be some possibility of saying, you can't actually do this now. You can't turn the NHS upside down in the middle of this pandemic. You have to pause. And if we get a pause, then that's the opportunity to really take the argument in the most public possible way as to why is this happening? What kind of NHS do we actually want? We know what they want. What do we want? And that, you know, at that point, we want to come out very strongly with what we want. We know what we want. I don't have to tell you. but we haven't had the opportunity to make that argument publicly, and we could get it. If we can force a pause in this and force the chance for the public to have a discussion, we might get somewhere, because one of the real lessons of COVID is that the private sector doesn't work. And that's an argument that we could win if we had the chance to actually talk about it. It wasn't the private sector that delivered the vaccination program. Yes, the private sector was involved in developing the vaccines, but actually AstraZeneca did that on the basis of government funding. The delivery of the vaccination program was entirely down to the NHS. That's how it was delivered. So, you know, IBM and all these health insurance companies, they weren't doing it. That's one component of it. The other component, as people referred to repeatedly, is that the privatized test and trace system simply didn't work. And that was very dramatic with the Delta variant, because what happened was that the Delta variant emerged at a point in time when the case numbers were actually very low, and that was the ideal point in time to actually carry out contact tracing. But they didn't do it because they didn't get the information to the people who needed it, which were the public health teams in the local authorities, for example, in Blackburn, where the thing was emerging and they didn't have the information because the centralized test and trace didn't give it to them. So there are very powerful arguments that can be made against the privatized approach to this whole thing. But the precondition for doing that is to at least get a pause in the bill and then open up the public argument. So I wouldn't be completely despondent. And I also, as I said earlier, I think that if the unions go into dispute over the 3%, there is every chance that we can make the argument about the bill as part of the public discussion that will go alongside their dispute. So again, I would not be despondent. I don't actually know anything about your union, and I'd be interested to hear more, and also to know whether you have any relation with any of the other unions and how that's going. But if you have any influence on how any of the mainstream unions that organize in the NHS are approaching this, you should scream at them that this is a crisis which will affect their members and that they haven't yet opened up on it. I raised points in my opening about the threat to national terms and conditions. Every union that organizes in the NHS should be really angry about this. And so far, they haven't. One of the very nice things that happened last night, to contradict what I've just said, is that the representative of the GMB, Rachel Harrison, did actually say, yes, this is a threat to Agenda for Change. And that's important. That's the first time anybody from a major union has said that publicly. And if you have any influence over what's going on in Unite or Unison or any other union, the main union organizing, please use it. So I hope that you will develop a relationship with KONP. Thank you for inviting me, and do consider writing something. I think it could be very interesting. Okay.
Okay, thank you very much, Greg. Hugely appreciate all your input and knowledge. It's been very, very useful. And I hope our members and members of the General Federation of Trade Unions, which we are affiliates of, will listen to this video, and that we will all have pause to think about what we can do and come together. Okay, thank you. And thank you all for attending, and to the organisers, thank you. And I will close this meeting.
Thank you so much for cheering so well, Juliet.
Thank you.
Cool.